Good morning, everybody. You know, it's time to go on a diet when you're wondering about whether you're going to fall through the floor. So if I suddenly disappear very quickly, bear with me. I just want you to pick up about what QUIP looks like and some thoughts on that. And I'm going to talk about 4 key things. When we think about QUIP, one of the things that's important for me is almost to take a step back. And when we look at the advanced countries across Europe and in the States, and we look at their healthcare systems, there's a huge similarity in terms of the kind of issues that all of these countries are facing at the same time. All of these countries are facing increased patient expectations. We all have better understanding about what good quality outcomes and what good quality care looks like. And we're all working in health economies where the level of resources that we need are being increasingly constrained. So the first message I think I would give about QUIP is we are not alone. And one of the things in understanding how we go forward with a comprehensive QUIP program is not only to look at what we're doing in terms of our own local health economies, but also to look outside and to think about what some of those messages may be. In looking outside and looking at how other countries and other systems are dealing with QUIP, let's focus on what we know actually works. Well, what we know actually works is effective clinical leadership. So there is a whole raft of international evidence which demonstrates that where we have effective clinical leadership providing some real drive and energy into improving quality standards, that we know that works. And so this is a real opportunity, I believe, for clinical commissioning groups as clinical leaders in the system really to grip hold of the QUIP agenda and demonstrate how we can actually drive forward. We also need to look at other leaders, and one of the people I often look to is Professor Cotter, who's a Director of Change at Harvard University. And what would he say about QUIP? He would say you need to drive at pace. We need to galvanize what we are doing across health economies and really put some zip and pizzazz into our move towards taking QUIP forward. And we need to be really clear that we get people to focus on the real drivers of change. What are the drivers which are underpinning the wider health and social care system, and not just focusing on individual organizations, but actually looking at the health system as a whole. The other thing we know that works is actually pulling together the talent that we have in the health community and with many of our partners outside to provide a real guiding coalition to push forward QUIP. The issue is not about whose responsibility is QUIP and what are the various boundaries in driving it forward. The issue is to make sure that we are all focused about the benefits for patients of driving quality up and making sure that we are working together and pull the talent we have together across the health community. Irrespective of whether that talent is in clinical senates or academic health science centers, or whether that talent is in CSUs or CCGs. Such is the nature of the task we're facing with QUIP. We have to pull people together under the clinical leadership of our colleagues in CCGs and working with our area teams who will also have a key responsibility for transformational change. What would be the characteristics that we would look for effective QUIP programs? Well, I think we would look for processes which are focused on driving up patient outcomes, supported by lean processes which are capable of operating across health communities, not just in individual organizations, but actual processes which can operate at scale. I think we would look for evidence and practical benchmarks of better integration, and not integration just across health and social care, but that is really important, but also better integration across the health system as we know it. And some of the challenges that we're facing with urgent care at the moment are real evidence of the need to work across the whole system to have everyone pulling in that same direction. My final point about QUIP is, as health communities, we need to remain focused on the prize. We are all duly proud of the health service. We all know that in our international comparisons we fare really well, and we can be rightly proud of many of the great things that we do as a health system. In order to maintain the NHS at the leading pack in terms of our delivery, we need to pull our folk together. We need to pull together the leaders in the health community, irrespective of where they are, to work together to really have a coalition to drive forward QUIP. Everybody has a role in that. Everybody from CCGs, commissioning support units, the whole community, and our colleagues in providers. Thank you very much.
Morning, everybody. So I'll build on what Andrew's said. The obvious answer to this is we're all responsible. And the one partner that we haven't talked about that we need to engage in this is the public. So actually getting patients and the public engaged in this debate, as Andrew said, it's not just something in England, it's something across the whole of the first world. So engaging patients and the public is crucial. The second is that when we talk about QUIP, we have a tendency to focus on the first P only. We talk a lot about the productivity, how we're actually going to become more efficient, how we're going to become more lean. I think it's really, really important that we actually remember that there are 4 bits of QUIP and they are all mutually interdependent. So focusing on quality, the Francis report has reminded us of the importance of that. We have to be innovative, and that means learning from each other. To be fair, we have to do productivity, but I would say that actually the second P, prevention, is actually even more important. What do I mean by that? I mean changing a service which at the moment is still very reactive and can still be very one-size-fits-all, to one where we really are actually looking out who are the people who are most vulnerable, older people, people with long-term conditions, people with mental health issues. What is it that we can do to actually personalise the service around their needs so that they don't end up defaulting to institutional care? And I think the example of some of the best work that's been done in social care around making people independent is something we can learn from. I think we also can learn from a lot of the work that's been done in mental health. If you look at the names of the innovations that they brought in, things like assertive outreach, early intervention, completely changing the model of care around is something that we need to learn how to do within physical health and within public health. So if that's the paradigm shift that we need to get into, what is it that commissioning support units can do to support particularly CCGs, but also other commissioners, and who knows, in time, providers and other players in this scene? We've sat down, we're very early into our existence, we've sat down and said, what are the things that we want to be, if you like, famous for, the things that we need to focus our effort on? And we've come out with 5 things, and we think that they are all relevant to the QUIP challenge. Basic is, if you like, supporting people to run their own businesses really well. What you might historically call back office functions like HR and finance. Absolutely crucial to get those things right. Second thing is using the best evidence and best information. We do sometimes make decisions based on what's gone before or the wet finger in the air, rather than actually saying, what is the evidence, what's the information telling us, how do we actually shape our actions around that? We have a crucial role to play there. The third is improving quality. We were set up at the time the Francis report came out. We've tried to shape everything we do to be Francis compliant and to support our CCGs to be Francis compliant, because there's a huge amount in there that we just need to get on and do. Delivering efficient services. Yep, some of that is about productivity, but some of that is about how do we underpin transformational change with good contracting, good performance management, all of the kind of tools which Professor Cotter would talk about that you actually need to underpin your good ideas. And then the fifth thing is the whole idea of service transformation. How is it that we are going to redesign services with people rather than for people? how is it we're going to do that with partners, not just with them feeling that they're being done to? And in particular, how are we going to harness the power of clinical commissioning to make really radical changes going forward? So I think that's our contribution, but as I said at the beginning, this is very much about a team game. Where do we fit within the team? Where do we put our shoulders to the wheel?
So the question is, who is responsible for delivering QUIP? As the previous speaker said, everybody, but we've really got to think about who is going to lead this. If everybody is leading, we have chaos. And I think there is a responsibility of CCGs to take a lead role in this. And not only to hold CSUs, who are the enablers for delivering QUIP, to account, but also to hold NHS England accountable for delivering their part in terms of helping deliver QUIP. So often people think of QUIP as a process, and this is something we've got to do, a drudge. We're into the, finish the 4th year, into the 5th year. But actually, what is it all about? And previous speakers have already touched on. And the biggest opportunity that we have in this final year is really thinking about have we got the most out of quality? Have we released innovation in the system, which we haven't managed to do in the past? We've concentrated a lot on productivity, but if we could just do more of the same, and we don't think about prevention, pushing the debate upstream, then we're going to be in the same position. We can't afford to do that. So you need to have CCGs beginning to take a strategic view over the whole system. And the whole system is not just the acute trust, but also community and local authority, the voluntary sector. And looking at QUIP as an enabler to transformation. It's not a means to an end in itself. It has to be part about changing the system. It is not only an avenue for cutting the fat out of the system in terms of productivity, but it is about how you can use it to help lever the biggest changes that we need to make, because the current system is not sustainable in the current form, and we all know that. Clearly, the impact of clinical involvement in this is absolutely critical. And when I've talked about CCGs beginning to utilise all the levers open to them, it is about utilising the clinical commissioners right at the front line, involving members of a membership organisation in terms of GPs and clinicians, to be able to understand what they're trying to do with QUIP. And that is absolutely key, because it can't be delivered without the front line being engaged. There are real challenges in doing this. If you're trying to integrate the system, issues of information, and still in the 21st century, this far on, we're talking about have we got enough of the right information. The second big barrier is information governance. I'm looking to CSU colleagues to sort this out, and pretty damn quick, because it is the ultimate barrier to integration. The will is there for people to start moving forward. We can't integrate within health itself, let alone within health and social care. And I think the time has come now to call upon our experts to sort it, and there's no other way of putting it, really. The CCG has a responsibility for part of the system in its locality, but NHS England has a part to play as well in terms of enabling CCGs to be able to deliver this, and working shoulder to shoulder with CCGs to be able to deliver this. I speak as coming from an area where we've made a £38 million efficiency saving in the last 2 years. Every year gets more difficult, and as we're coming towards this time in the programme, it is going to be more difficult. And unless we think much more strategically and holistically, we're going to be putting our providers in real difficulty if we don't think of transformation. So we're at that cusp where QUIP is actually the birth of transformation if it's not already started taking place. Thank you.
Thank you very much. We haven't got a huge amount of time, so shall we take questions, perhaps take 2 or 3 questions to start? If you want to put your hands up with any questions.
Or not.
This is a question for Dr. Agnelo Fernandes. You talked about making £38 million of efficiency savings. So what have you done to kind of share your best practice with kind of other CCGs in trying to get, best practice and best evidence of how to make these efficiencies?
Any other questions at the moment? Do you want to start with that one, Agnelo?
I'll be speaking at 12 o'clock and let you know. However, it's a fair point. The problems in the NHS we've known about for decades. The solutions are also there in the NHS, but we never actually share them. We have this not invented here syndrome. It may work somewhere else, but it doesn't work here. And I think we need to break down some of these barriers. It's not about spoon-feeding people. If you hear about something, go and find out about it. So there's something about taking the initiative to, if something is working somewhere, to go and find out about it. And I think in the past, dissemination of information has been somebody's got to do it centrally, or you got to do it. If you're really interested in making a difference in your locality, you've got to get up and go and look for where it's working. And because there's something working everywhere, and the solutions are there in the NHS, and we've been saying that for years.
Sure.
I'm just going to add a couple of things to that. I think that CSUs, as part of our responsibility, is to actually work with people like, for example, NHS Improving Quality, the successor to some of the previous improvement bodies, with NHS England, to actually identify what has worked with real evidence. But I think the other thing is that my experience of clinicians is that they are actually much better than sometimes managers in terms of just sharing stuff and using new media to do that. So if you follow people on Twitter, which I never thought I'd do, it is really interesting, just picking up very interesting stuff which people are doing in a very open way. They're very happy to share it. They're very happy to hear about what you're going to do. So I think that having clinicians involved in commissioning will open up innovation in a new way.
The one area I just wanted to emphasize is something that John picked up a minute ago, which is when we are undertaking transformational change, the kind of choices and discussions we're making about how we care for our loved ones are far too important for them just to be a discussion amongst health professionals themselves. And we really need a step change in how we think about transparency, engaging and consulting with the public and with our wider communities in order that we can get far better traction about how we how we move things forward. Just coming back to the issue about CSUs, and one of the things around transformational change is it just requires such a level of meticulous planning that actually we can't ever be paranoid about individual roles between CCGs and CSUs or trusts or providers or senates or networks. Within what we have to do, there is a place for everybody in that team to really make a difference for QUIP. And the success of QUIP will be guided by how effectively that guiding coalition for each health community really works together and really looks towards making some quite radical changes in how we actually deliver services.
Any further questions? One down here. Yeah, microphone in. Question at the back first.
All right. Thank you, gentlemen. My name is Joseph Way. I'm with Country Court Care, and we're a private provider of residential care and home care. And whilst I've heard everything that you guys have said, I'm sure I'm not the only one here who's standing here scratching their head and thinking, how does all this pan out for me as a provider? Because Dr. Fernandes mentioned, I think he was the only one that mentioned it, that we need to be looking at the social part of it as well. All of it seems to be so much health focused. But at the end of the day, the people who deliver the hands-on support in the vast majority are private providers of care. How do you see private providers of care being an integral part of QUIP at this point in time? And do you have any suggestions for providers like us going forward?
Should we take one more down the front?
actually started by talking about.
Hello, Dan Rickson. I'm also an independent business consultant. It's a very similar related question about the third sector. You could take any health economy, any local community, they probably have 4 or 5 things they want to solve. They probably have the project or the initiative or the transformation in mind, but don't know how to fund it. And I wonder whether that's a cop-out or whether it is a real barrier. At the moment, we don't know where the improvement budget is for local projects or local change or network-driven change, something like that.
Do you want to start on that one, John?
I was going to volunteer for the first question, but I'll touch on that. The second thing I said actually was about what can we learn from social care, because I think that because social care has come under financial pressure even more so than the health service, I think the stuff that they've done around really enabling people to look after themselves or provide the support to look after themselves so they don't default to institutional care is an object lesson for us. And the second was mental health. Now, in both those sectors, private providers are much more prevalent than they are in other bits of the health service. And I completely agree that some of the innovation from the private sector and from the voluntary sector, we need to learn from that. I'm learning, setting up a new business, that some of those commercial disciplines actually help us to drive innovation, and I agree we should look to other sectors for that.
Just to reiterate, we can't assume within the NHS we have all the answers. Folk in universities, folk who have business experience, folk from other health economies all have something to bring, and we should embrace them rather than seeing them as a resistor. They can help us thinking how we actually make the QUIP transformation.
Can I just say, if we're really serious about transformation, then everybody is around the table and thinking in a unified way, because you can't have a transformation program with the third sector or the voluntary sector excluded, or social care excluded, or the private sector. It's about who are the providers, who are the commissioners, is it health, is it social care? At the end of the day, that all gets blurred because you're thinking about how is it you can improve the quality of care for individual patients, improve the quality of their experience, and how can you do it as effectively, both in terms of the clinical outcomes, but also in terms of the costs. Because the one thing we know, there isn't the money. So effectively, we need to find solutions.
Shall I just, and to be fair, we haven't answered Dan's question, so where do you find the seed corn? Two ways. Actually, there is, CCGs are required to set aside a non-recurring surplus. We're required to do the same. FTs have their own surplus. What we have to do, though, is to actually pool some of that, because what tends to happen is that everybody looks at that pot and says, oh, I'll use that to fund my cost pressures, rather than actually saying, no, we've got to absorb our cost pressures. We really are going to have to use that stuff to seed major change.
I think the other comment I'd make about that, it's about doing the maths. So let's look at, so what is the opportunity cost of not focusing on transformational change? And what will that actually mean for each of the respective organizations in the health community? And often that contribution in pulling together that brain power to really guide the QUIP programs is about time and is about priority. And it's really important that every one of the organizations, the community groups, our colleagues in social care and other areas see QUIP as the main deal. This is the thing we need to be focused on, because this will be ultimately the main determinant of the improvement of patient care as we go forward. And when we look at the amount of resource we spend in every health and social care community, if we were explaining to patients that we cannot find the resource or time to really bring about the best healthcare, I think that's a difficult thing to justify.
Okay, I think we've got time for one more question. There's one in the middle there.
Thank you. Nigel Sloan, Managing Director at Solace. Agnelo, delighted to hear you make the comment that information governance is the greatest barrier to integration. I couldn't agree more. you threw the challenge out to the rest of the panel and indeed the floor, I imagine, in how do we get this fixed. So I'll replay the question back. How on earth do we get this fixed? Because the clinical commissioners that I talk to on the ground are aghast, and that's a polite word for it, that they cannot get access to the intelligence they need to do their jobs.
Can we kick? Well, Agnelo threw the challenge down to CSUs, so I better pick it up. We are slowly making things easier for ourselves at a national level, because to be fair, there have been some impediments, particularly between health and social care. So unfreezing that is really important. I think that we have some of the technical expertise to actually be working at that, but also to be candid, some of it is also about a mindset. It's actually about getting clinicians, professionals to be happy about sharing what they sometimes see as their data. And that's where clinical leadership is fundamentally important, is getting people to say, it's not our data, it's the public's data, and unless we unfree it, we're never going to improve things for them.
So, Dr. Fernandes, you set out the challenge on that, and the challenge is sort of coming back to you. What do you see as the specific problem here?
I think, to put it in a simplistic way, jobs worth. You can interpret guidance in whatever way you want, but at the end of the day, what are we trying to do here? We're trying to improve the quality of care for people by sharing information, being able to share information between organisations. And to me, that's the holy grail. And I think the experts that advise us on this and really have to have a high risk appetite in terms of being able to solve the problems. So rather than rehearsing the problems, actually solve them for us so we can get on with things. You know, we're on a platform where we just got to get on with things. And that is that everywhere I go and everyone I speak to, that's the major impediment in terms of integration.
I never thought I'd be on a stage and sound corporate, but you know, bear with me, I'm going to try to do this. The issue is not about jobs worth, the issue is about the law. The law is the law, and actually, if any statutory organisation does things which are counter to the law, there are serious repercussions for clinical chairs, for accountable officers, because you are knowingly going against the law. Now, there is nobody in NHS England or nobody in the CSU community that does not understand the importance of fantastic information at driving forward QUIP, at making a real difference to you as CCGs and to really improving patient care. And what we are doing is trying to work through with the Health Information Centre, with CSUs, with CCGs, a really complex legal issue, which is around how do we appropriately use information and make sure that the checks and balances are in place. I feel more frustrated than anyone, and I absolutely sense everyone's frustration about this issue. However, pretending that it is not a practical legal issue which has really fundamental impact on how statutory bodies impact or work isn't actually focusing on the real issue. So we understand the issue and we are working really hard to find a way through it. But the issue is not about people who have different jobs in different organizations. The issue is about the law, and it is about how that law is applied and interpreted in a new health system. I'm confident that we will work through it, but we need to just understand that that's the nature of the problem.
We're going to have to wrap up there, and if we could thank the panel very much.
Good session. Thank you. Well done. That's good. That's good.
I didn't mean to be nasty.